Hello, this time we can say definitely this is the last part that fits into digestive system anatomy and physiology. So I was a little bit over optimistic with part number 4 that we would be able to put everything into one single video, but this time I think that we're going to have it done properly and as per wishes. So let's go into a next step of our studies and let's open up the slideshow to help us out go through the outstanding part of anatomy and physiology of digestive tube. So I suggest that we start from blood supply to the digestive tube just to make sure that we understand really what is going on here and to use it perhaps as a slight review. As I'm sure you would remember, the digestive tube is supplied through three main single branches coming off the abdominal aorta, the celiac trunk at the level of T12, superior mesenteric artery at the level of L1 vertebra, and at the level of L3 vertebra comes the inferior mesenteric artery. Pretty much these three vessels are supplying not only the digestive tube, they also provide blood supply to associated organs such as liver, pancreas, but also spleen, which is just physically fitting into upper left quadrant of the abdomen, but doesn't fit into digestive tube. So let's take a look, see here what celiac trunk yields. It's the first of the three branches. So if we follow this branch that goes all the way to the right, that is the main hepatic artery, which provides arterial blood supply to liver in order to support with additional amount of oxygen hepatocytes. Although it only comprises about 30% of the blood the liver receive, remaining 70% is going to come after we drain the venous blood from the digestive tube, and through vena porta we bring it back into liver. So celiac trunk, it's easy to remember because obviously it supplies the uppermost situated parts of the abdominal cavity. Liver being one of them through the main hepatic artery. Then the second branch of the celiac trunk, as you can see, goes behind the stomach, and it is the splenic artery. And then the third branch of the celiac trunk is the left gastric artery, obviously taking care of stomach, passing along its lesser curvature. We also have additional blood vessels such as the right gastric artery coming from gastroduodenal to cover remaining parts of the lesser curvature. Also the right gastromental and left gastromental arteries doing more blood supply along the greater curvature of the stomach. However, we are immediately to start seeing what's happening in the world of veins. Basically, we have something fairly comparable, that arteries and veins are running parallel to each other. Here is the spleen, and of course, the splenic vein, which doesn't only drain the spleen, but also drains a bit of pancreas. I forgot to mention that splenic artery, through its small branches that are sent directly into pancreas, are doing pretty much major blood supply to pancreas as being part of the digestive tract as well. Left gastric arteries, here we have left and right gastromental veins. Sorry, I said left gastric artery, left gastric vein, and a right gastric vein. So more or less, it really looks like fully comparable between arteries and veins, that they are next to each other. Should we go to the next slide, I want to introduce the superior mesenteric artery. The superior mesenteric artery takes care of practically jejunum and ileum. Duodenum is receiving more blood from gastric arteries and gastromental arteries together with the head of the pancreas, which is sitting here, while the superior mesenteric artery really supplies all the blood needed to go to jejunum as well as to ileum, and it doesn't stop there. Additional branches of the superior mesenteric artery supply cecum and appendix, ascending colon, and the proximal half of the transverse colon. So what is left of the digestive tube is left for inferior mesenteric artery, which provides additional blood supply to the distal part of the transverse colon, descending colon, sigmoid colon, and some additional branches that will go to the proximal rectum. Okay, so we would need to look for some kind of analogs of superior and inferior mesenteric arteries in the form of veins. And were to find it very shortly, this is just a different view where you can use it to perhaps better visualize what celiac trunk yields. Common hepatic artery, splenic artery with its pancreatic branches. This branch here is pancreatico-duodenal, supplying part of the pancreas as well as duodenum. And we also have the left gastric, which runs over the lesser curvature of the stomach. Another view to kind of visualize how many different branches of the superior mesenteric artery and which parts of the digestive tube it supplies: jejunum, ileum, cecum and appendix, ascending colon, and proximal half of the transverse colon. Finally, one more diagram to address the inferior mesenteric artery with its branches: transverse colon, distal part, descending colon, sigmoid colon, and part of the upper rectum receives arterial blood through inferior mesenteric artery and its branches. This is what looks more important and more relevant, not only from a point of view of seeing where exactly inferior or superior mesenteric veins originate, but rather what's going to happen to them. So superior mesenteric vein actually drain the venous blood from the same parts of the gut that superior mesenteric artery supplied with arterial blood. So it's jejunum, ileum, cecum, appendix, ascending colon, part of the transverse colon. Inferior mesenteric vein does the same as what the inferior mesenteric artery has done: transverse colon, distal part, then we have descending colon, sigmoid colon, and rectum. However, this is now the most relevant and most important thing. Inferior mesenteric vein, on its way up through the abdomen, basically joins the splenic vein. Now they run together from this point on, which is happening posterior or behind the stomach, and then union of the inferior mesenteric and splenic vein joins already huge size-wise superior mesenteric vein, and then when they are all merged together, the end result is production of portal vein, vena porta. Vena porta obviously runs to the underside of the liver, enters the liver through hepatic porta, which means the gate. So this is portal vein that goes through the gate into liver, and it brings 70% of blood into hepatic tissue for further chemical processing. Mind you that the blood collected from digestive tube is enriched with all the different nutrients which have been absorbed, some of them being essential, some of them non-essential. But as they're going to pass first through liver is going to eventually do some kind of metabolical processing and detoxification of certain absorbed molecules before they become released into systemic circulation. I'm going to add it here with portal vein, basically, and its blood flushing through liver. Basically, when the liver completes its job on its upper convex or diaphragmatic side, we're going to see appearance of multiple hepatic veins through which blood from liver is drained into inferior vena cava. So I hope that this review of blood supply to digestive tube has been pretty good. And now we can take a look together and start talking about other two important organs, liver and pancreas, and of course the gallbladder, which appears to be organ on its own. However, because of its proximity and its function, basically I always prefer to talk about it together with a liver. On this diagram, in the sagittal section through the abdomen, we can see the curvature set by the diaphragm, the dome-shaped muscle, and immediately what sits under the diaphragm is liver, separated from the diaphragm with some very minimal space, part of the peritoneal cavity. And this blue highlighted surface is called the visceral surface of the liver, which is, as you can see, pointing more posteriorly than just inferior direction. And that is a contact surface where liver comes into direct contact with a number of different organs of the abdominal cavity. The most important and most significant for us is to really go back to duodenum, part of the small intestine, retroperitoneally positioned, along with the pancreas, which is also retroperitoneal, because the duodenum really becomes that kind of main connection point between pancreas, liver, and biliary duct with the digestive tube. So we know that duodenum, which is about 20 to 25 centimeters long, sits behind the peritoneum, and it has a couple of interesting landmarks, which we did not mention earlier, but we're going to say a few words about them right now. There are two openings, one which is called the major duodenal papilla, and the other one, slightly more proximal, the minor duodenal papilla. So this one is minor, this one is major. And as you can see, the illustrator made the pancreas looking more transparent. Obviously, it is the pancreatic ducts that are gaining direct opening at major and also at the minor duodenal papilla. This makes sense because even from just glancing on this diagram, you can see how the pancreas manages to empty its exocrine secretion directly into duodenum and to allow it to mix with the chyme which has been released from the stomach. Pancreas, as the gland, is relatively simple to define and to describe, speaking about its anatomy. We have its largest part, which is called the head, fitting very intimately into concavity set by the duodenum. And there is a part of the head which is kind of a little bit more in the shape of a hook, and hence it's called the uncinate process, although it is not marked on this diagram. From the head and uncinate process, we go through the pancreatic neck, obvious narrowing of the pancreatic tissue, and then we follow the pancreatic body, and then tapering off the tail of the pancreas, which comes pretty much directly, and occasionally it touches even the medial aspect of the spleen. Pancreas itself is about 10 to 12 centimeter long gland, but its size is pretty much in a direct disproportion compared to importance that we have. As we know, pancreas is a mixture of both exo and endocrine gland. Exocrine pancreas accounts for about 99% of its secretion, while 1% of endocrine pancreas through its acinine is actually secreting insulin and glucagon, two different hormones that are controlling levels of blood sugar. Since we're not talking much about other glands with endocrine secretion, we will focus mainly on the pancreas as the exocrine gland. So its daily secretion ranges between 1 to 1.2 liters of clear fluid, which is not only adding more water into digestive tube, but it's also producing significant amount of bicarbonate ions that are released into duodenum. Keep in mind that acidic content, which could be quite acidic coming from stomach, whereas pH could be easily between pH 2 or 3, needs to be quickly offset by additional alkaline substance. And pancreas is doing it in a pretty much perfectly tailored form, not producing too much, not producing too little, and pancreatic secretion practically changes the chyme to run in between ranges of pH value between 7.1 to 8.2. That is optimal for some enzymes, to become activated so that process of a chemical breakdown continues going through. Pancreas, as we know, secretes a number of different enzymes. Some of them are in an inactive form, such as trypsinogen or chymotrypsinogen, protein digesting enzymes. Their activation happens within the lumen of duodenum. Otherwise, if we have a pancreas producing directly trypsin and chymotrypsin, there could be a problem because these enzymes could start breaking down even pancreatic own enzymes. Pancreatic amylase, another hormone which is secreted by pancreas, comes in an active form, and it continues breakdown of carbohydrates. Pancreatic lipase is another important hormone that helps us with the breakdown of lipids. And then ribonuclease and deoxyribonuclease hormones, enzymes required for further digestion of ribonucleic acids. Everything, of course, with lots of fluid and lots of bicarbonate ion to offset the acidity. So the exocrine pancreas, with its massive secretion, as you can see, practically secretes into its main pancreatic duct, which is also known as the duct of Wirsung. Main pancreatic duct starts at the tail, runs through the body and neck, and through the head of the pancreas. Basically, it reaches the major duodenal papilla, where the main pancreatic duct opens and secretes into duodenal lumen. However, this little square that you can see is actually the same area being enlarged on the right side of the screen because there is a moment of surprise. The major or main pancreatic duct of Wirsung, actually before reaching the major duodenal papilla, first has to merge with a common bile duct, which obviously brings bile from liver and gallbladder. As they merge together, they actually form a slightly enlarged tubular space, which is known as the hepatopancreatic ampulla, or ampulla of Vater. The hepatopancreatic ampulla, obviously secretion from hepar, liver, and pancreas, hence the pancreatic, are coming together, and then in a form of mix, they become released through the major duodenal papilla. It is important to add here that pancreas cannot afford secretion that is done for no particular reason. And of course, there could be time, especially when we're fasting, where we simply have to allow pancreas to recover and to be ready for another food intake. And as a result of that, we have circularly running muscle around the major duodenal papilla. That muscle is called the sphincter of hepatopancreatic ampulla, or what people call it more typically, the sphincter of Oddi. Obviously, closing of the hepatopancreatic ampulla will prevent uncontrolled leak of bile or pancreatic juices into duodenum when the time is not optimal. I just want to add here that it's not only this single sphincter, the sphincter of Oddi. There's another one which is a little bit less known. However, I'm going to add a couple of lines here in red ink, and I'm going to present this to you as additional sphincter, which runs only around the common bile duct. This sphincter, when it's active, when it contracts, can prevent uncontrolled loss of bile, because we know bile is needed for digestion of lipids. And some of our meals could have no lipid content at all. So during those moments, basically, we're trying to preserve the bile and to store as much of it in the gallbladder. Storing it, of course, means also making concentrated bile. So this sphincter, which is wrapped around hepatic common bile duct, is called the choledochal sphincter. Cholium means bile, and docus means duct. So cholium, choledochal sphincter, which controls secretion and release of bile into duodenum. So let me just complete choledocus, CHUS. So you have the name of the second sphincter in the area. Okay, that is the main pancreatic duct, and that is the area that we have observed together. So that's where bile and most of the pancreatic juices reach the duodenal lumen. Possibility and probability that something can go wrong. Let's say production of bile stone and eventual impact of the bile stone within the hepatopancreatic ampulla could trigger really very unwanted and very life-threatening moments where a pancreas eventually becomes fully blocked. Even if this happens, pancreas has a way out, and it has the secondary duct, which could use for drainage of pancreatic juices into duodenum. It is called the accessory duct or duct of Santorini, and it has its own opening, which is more proximal than hepatopancreatic ampulla. Basically, it is minor duodenal papilla. So the only question that we have to answer right now is how the pancreas knows when to secrete, when not to secrete. Well, there are a couple of things. As we know, we have pretty much all the locally elicited reflexes that are controlling events of the digestive tube. So pancreatic secretion will intensify upon arrival of chyme, acidic chyme from the stomach into duodenum. As the chyme is extremely acidic and potentially could burn through the walls of duodenum, pancreas right away is going to be stimulated to do more of its alkaline secretion. It is regulated through the parasympathetic nervous system, but also entry of acidic chyme stimulates the release of secretin. And the secretin stimulates pancreas to start or to intensify its own secretion. Also, with the presence of partly digested proteins in the duodenum, could release or stimulate secretion of cholecystokinin, which again is stimulating or enhancing effect of secretin on the pancreas. The pancreatic secretion obviously has to include all the different enzymes that we previously mentioned, and with change in the pH value from very acidic to mildly alkaline, basically pancreatic enzymes become activated and the chemical breakdown is further continuing. So we do not have any major or very complex moments around which we have to work. So the pancreas, the way we describe it, is practically now up our way, and we need to focus a little bit closer onto anatomy of the liver. For that reason, I'm just going to go back for this slide to point out liver is large organ. It's solid and it's located mostly in the upper right quadrant of the abdominal cavity, where a minor part of the liver from midline to the left is projecting also into upper left quadrant. Most of its surface is in direct contact with the diaphragm, of course, not being adherent to it, but just physically very close. And it conforms with its shape and texture to smooth underside of the liver. So highlighted in red is part of the liver that we consider to be its diaphragmatic surface. The liver, unless it's enlarged, is really not palpable organ because most of it sits protected deep under the ribs cage. And only when a slight enlargement of liver is expected, basically liver could be palpated. And this is the palpable anterior margin of the liver, intersection between the diaphragmatic surface in red and inferiorly and posteriorly positioned visceral hepatic surface. Basically, there's pretty sharp contact point between these two surfaces, resulting in so-called anterior border of the liver. Liver is encapsulated in peritoneum. We consider it to be intraperitoneal, as most of its surface is covered with a peritoneum. Only part which is not is area that is called the bare area, and it is oriented posteriorly towards the diaphragm. Bare area of the liver has a little bit more granular appearance, so it's not as smooth and shiny as the bulk of the hepatic surface is. So the diagram that we have actually removed most of the diaphragm, so we can see the liver sitting under the posterior half of the diaphragm. And right away, we can make conclusion, which is obvious, that bulk of the liver actually is composed of two major lobes, the right and left lobe of the liver. An organ of this size and this weight, about 2 kilograms in an average person, simply has to be properly secured to the underside of the diaphragm. And that is where the peritoneal folds that are running between diaphragm and liver form what we call the coronary ligaments. And I'm adding just what coronary ligament should look like to give you a bit of idea, both on the right as well as on the left side. That is the coronary ligament, and it is also labeled here. While in the midline, we have another derivative of the peritoneum, which is called the falciform ligament. It comes from the Latin term falx, which is a term that defines sickle, the agricultural tool, and that's the shape of the ligament, shaped like a sickle's blade. Falciform ligament also anchors the liver to the underside of the diaphragm, but in its inferior and free margin, it'll contain another important structure, which is called the round ligament of the liver, ligamentum teres hepatis, round ligament of the liver. Actually, it used to be the umbilical vein. So before birth, umbilical vein was bringing oxygenated blood from a placenta into fetal body. After birth, of course, the umbilical vein collapses and becomes occluded, and after that becomes known as the round ligament of the liver, being contained within the falciform ligament. Should we have a better view to see the underside of the liver, you and I will see something that looks a little bit different. I'm going to use this picture here just to point out whereabout is this huge opening that we have on the hepatic's visceral surface. That is hepatic porta, the gate of the liver. And even on this diagram, you can see quite nicely that hepatic porta is having three major structures that are getting in or out of the liver. Two that are coming in, common hepatic artery in red, blue-colored portal vein, 30 and 70% of blood supply respectively. And what comes out of liver at this point is actually like biliary ducts coming from right and left lobe, joining together to become common hepatic bile duct, and then joining the cystic duct, obviously bringing bile from the gallbladder. On this underside of the liver, we can actually see even more partitions that will bring a bit of change. It's not only about right and left hepatic lobe. Liver has two additional smaller lobes that are seen only on the hepatic underside. The one which is closer anteriorly is known as the quadrate lobe, and then the one which is sitting more towards back, marked with a second arrow, is called the caudate lobe. Quadrate, square-shaped, caudate, shaped like a tail. These two lobes, although they look physically being on the right side of the liver, are functionally part of the left lobe of the liver. So that brings a little bit more balance, because right and left lobe, like this on the diagram that we have in front, look like right significantly larger than left. With addition of two smaller lobes, the quadrate and caudate, and allocating them through their blood supply, through their biliary drainage, to the left side of the liver, we're having a little bit more balanced situation. As one can see, lesser omentum, which we attached onto the lesser curvature and the most proximal part of the duodenum, is running from stomach to the underside of the liver. And what is important is that within the lesser omentum, at its lateral boundary, basically we have this hepatic or portal triad consisting of bile duct, branch of a hepatic artery, and the portal vein. So that is how they get wrapped up in the peritoneum before they are finally advancing into hepatic tissue. On the opposite side of the stomach, along its greater curvature, as we can see, there is attachment of the greater omentum hanging freely downward before folding up and reattaching to its anterior surface of the transverse colon, which could be quite hinted here. Maybe I can just highlight its presence so that you do not wonder where is it, but now you can see it a little bit better. So this is what happens to greater omentum. It goes from greater curvature of the stomach downward, and then it makes U-turn 180 degrees going upwards, so it becomes attached to the transverse colon. Other than that, anatomy of the liver is fairly simple, so we would be best off by taking a look at the individual basic building block of the liver, so-called the hepatic lobulus, not the lobe, but rather smaller part of the lobe. All the lobuli are inside the liver, and they're hexagonally shaped. So hexagons, as we know, are a straight figure from geometry that we learned a long time ago. So if I'm putting two hexagons together like this, excuse me, they have good match, but now when we add one more here, it's going to be also a perfect match, and then we can add one more here. And should we continue in this form, basically we will be looking for more hepatic lobuli to be illustrated. So as we focus on one of them, which is the middle part of the screen, you realize its hexagonal shape is quite directly visible. And then it is surrounded by network of blood vessels, branches of a hepatic artery, branches of a portal vein, and green-colored vessels are bile ducts. So we have a need to take a look and see it enlarged, not even to see the entire lobulus, but rather part of it. So we can see what is the structure, what's the architecture of hepatic lobulus. Branch of a portal vein, which is very peripherally located relative to lobulus, is opening up, and it drains the venous blood into capillaries that are very specific type. They're sinusoid capillaries, quite wide and irregular in shape, so they actually slow the blood flow down. Why the blood needs to slowly move through liver? Because it carries a number of different nutrients, whatever we have absorbed from a digestive tube, and we have to expose those compounds to hepatocytes, liver cells, which will actively do the uptake of absorbed materials from a sinusoid, and they can also go the other way to release it into sinusoid capillary. So blood flows from peripheral parts into the center part of the lobulus. Of course, more blood comes in through the branches of the hepatic artery, but that is, as we know, oxygen-rich blood supply, also needed for hepatocytes. Lots of reticuloendothelial Kupffer cells are seen. They're part of system that can go easily move through sinusoid capillaries, and they're part of the reticuloendothelial system. So when the blood has been circulated through a hepatic lobulus, basically it is drained into the central vein of the lobulus. It will be this little circle that I'm putting into hexagons on the left side of the screen. Of course, blood moves out of the lobulus. Basically, these vessels from adjoining lobuli become merged, become bigger, greater, and at the end of this journey, basically they converge on the upper surface of the liver, where I'm making a little bit of a circular sign. I hope you can see this. And as a result of this, emergence of so-called hepatic veins becomes obvious. They run a very short distance into inferior vena cava, which finally receives the blood, which has been chemically processed by liver, and that is now part of the systemic circulation. Essentially, the byproduct of hepatocytes is production of bile. So we can see here between these two rows of hepatocytes appearance of very small bile canaliculus or bile canaliculi, if we're talking about plural form. And bile being produced by lobulus does have a different direction. It moves from center outward to periphery of the lobulus, where it's finally going to be pushed into small but significant biliary canaliculi that will be running opposite direction from blood vessels. So liver, as it makes bile, basically makes it pretty much 24/7. And as the end result of this accumulation of bile from right and left lobes of the liver, including quadrate and caudate lobe, basically the bile finally becomes collected into either right or left hepatic duct. This bile is very much dilute, and we need it. Production of bile could be also pretty intense based on type of food that we consume. We know that bile is needed for digestion of lipids, for production of micelles, and of course, more lipid intake will require more direct involvement of liver, which keeps producing bile as the chyme comes in. Keep in mind, hormone cholecystokinin is the one which also stimulates for more hepatic secretion and also stimulates contraction of the walls of the gallbladder, which ejects into digestive tube even more of a concentrated bile. So what happens as the left and right hepatic ducts unite? They form a single vessel coming out of the liver through the hepatic porta, and we call it common hepatic duct. Common hepatic duct, duct coming from liver, from hepar. On its way down into direction of hepatopancreatic ampulla, basically common hepatic duct becomes named into common bile duct. When? Only when a common hepatic duct carrying dilute bile joins the cystic duct from a gallbladder carrying concentrated bile. So regardless of the bile source, whether it comes from a gallbladder or directly from a liver, bile is bile. And as a result of this, common bile duct is the one which brings bile into hepatopancreatic ampulla, where it joins with the main pancreatic duct, and through sphincter of Oddi, major duodenal papilla, finally bile finds its way into duodenum. And this is ordinarily happening after an average meal. So what happens after a meal was pretty much lean on proteins. Now I hope that you will recall the choledochal sphincter which blocks flow of bile while maintaining viability of the main pancreatic duct and access for pancreatic juices into digestive tube. So we can say that at the very distal end of the common bile duct, those four straight little lines that I added are making the choledochal sphincter. And as this sphincter is active, basically it blocks the common bile duct. So this is happening. Liver is still metabolizing, and more of the dilute bile keeps coming from liver's lobes. But bile cannot be utilized during fasting hours. Neither we have always need for excessive amount of bile. So contraction of choledochal sphincter will reverse the flow of bile to go upwards through the common bile duct to cystic duct, and then to enter the gallbladder. And as the bile is passing through the neck and the cystic duct, neck of the gallbladder, basically at that point, it becomes pretty much intensely concentrated by removing surplus of water and creating a dark, thick, dark green colored fluid, which could be then stored within the gallbladder. And we're talking about 50-ish milliliters of concentrated bile being common volume that we can store within the gallbladder. Perhaps this picture will now help a little bit to recap. As we can see here, major pancreatic duodenal papilla, hepatopancreatic ampulla, sphincter of Oddi, and then sphincter of bile duct, the choledochal sphincter, and yet another pancreatic duct with its own sphincter, because again, there could be time when we want to preserve pancreatic secretion as nothing comes into duodenum, so pancreatic duct may have to be temporarily closed and allow for pancreatic tissue to recover and to be ready for the next meal. On the left side of the screen, we can see the gallbladder quite nicely illustrated with its fundus being the only part which protrudes further anterior to the hepatic anterior border. That's the fundus, which means actually the bottom. Then we have the body, the main part, and the body tapers itself down, turning into the neck, and then neck becomes the cystic duct. The mucous membrane, which is lining the neck and the cystic duct, is the one which absorbs lots of water. So that's why inside the bladder, we are talking about 50 milliliters of concentrated bile, which could be held there pretty much until the next time we need more bile for digestion, such as, let's say, eating for breakfast a couple of scrambled eggs or using some butter and cheese. As we know, they contain large amount of lipid molecules, so production of bile at that point will be quite required. We have on the same diagram right and left hepatic ducts, their union to form common hepatic duct, and then with addition of cystic duct to common hepatic duct, actually we're seeing the common bile duct, which forms the hepatopancreatic ampulla. For another just viewing experience, that is the underside of the liver with gallbladder fossa, a little bit of indentation, which allows more inconspicuous form of positioning of the gallbladder. Basically, we know that only fundus could become palpable, but it's especially happening if, for whatever reason, gallbladder is enlarged. And enlargement of a gallbladder is typically a consequence of gallbladder producing and unfortunately having inside its lumen some gallbladder stones. It is one of the very typical and common condition, more affecting women because during the pregnancy there is a huge compression on the gallbladder, which eventually allows for easier precipitation of bile salts and they're turning into bile stones. For as long as they are not capable of blocking the biliary pathway, basically it could be without any signs or symptoms. But if the size of a gallbladder stone is big enough to obstruct either cystic duct or common bile duct. Basically, at that point, we have some form of medical emergency that'll require surgery eventually to get rid of these stones and to ensure that we have a patient who is now capable of, again, digesting lipids. I'm not going to elaborate into types of surgery because once upon a time, like we're talking about historical distance of maybe 30, 40 years, usually surgery was just one type, removal of the entire gallbladder. And that's why people after the surgery would have a couple of months of very intense time to not just recover from surgery, but also to pretty much be subject to very strict diet because without gallbladder, they were not able to immediately start digesting lipids until the liver gradually becomes a little bit more trained and produces larger volume of bile after meal contained some additional lipid molecules. Nowadays, if possible, a small opening could be made on the wall of a gallbladder, special long instrument could be inserted, and basically with a forceps, and if specifically if single biliary stone is formed, it could be removed. The defect on the gallbladder is stitched, so practically recovery is happening within 1 day after surgery because basic anatomy has not been disrupted. Gallbladder is still there, still could concentrate the bile and do it pretty much just the way it was doing it before the surgery. So I hope that with this recording, we can now say that we're wrapping up the anatomy of digestive system. And there will be 2 more parts that I need to record and to post: anatomy of urinary system. And along the urinary system, we're going to add a few words about a reproductive system, both male and female, and to say a few words about the endocrine system. So stay with me. Hope that you are going to enjoy these videos. I really tried my best to present them in a relatively condensed form without focusing on the tiny, intricate details, but rather to use these videos as some kind of good navigation tools. That is traditionally what students are saying, offering a big picture that sometimes is actually quite handy. Well, thank you for watching this, and until next video and next posting, be well. Thank you for watching it. Take care. Bye-bye.